Association of Endometriosis, Adenomyosis, and PCOS. We are based in the beautiful multi-island country of St. Vincent and the Grenadines, located in the Caribbean. And one part of our mission is to raise awareness and provide educational sessions on endometriosis, adenomyosis, PCOS, and fibroids to the women that we serve in St. Vincent and the Grenadines, and as well regionally and internationally. Because education is needed, and I believe that knowledge is power, and the more that we know about our bodies, the more that we know about these conditions, the better that we can advocate for ourselves and advocate for others. From Australia. So tonight we have one of our faves, Dr. Colon. He is always willing and able and always to help us with putting on these educational sessions. We are so thankful for him, and we are looking forward to another informative session. I'm just kindly asking that we keep our mics on mute, and at the end of his presentation, we will take some questions. Okay? You can put them in the chat. You can send them privately, or you can just put them in the chat for everyone to see. We will not get to all of the questions because we do have a time limit here. And hi everyone. We do have a time limit, so we won't get to all of the questions, but I will pick the questions that are more general and ask him those at the end of his presentation. So Dr. Jose Eugenio-Colon is a world-class endometriosis and minimally invasive gynecologic surgeon and associate physician at the Center for Endometriosis Care. He is also an adjunct professor in the Department of Obstetrics, Gynecology, and Women's Health in the Division of Minimally Invasive Gynecologic Surgery at St. Louis University School of Medicine. A high-volume board-certified surgeon, he specializes in minimally invasive surgical care and laparoscopic excision of endometriosis in all forms of the disease. He also continues to donate his time to training the next generation of surgeons by teaching globally. Dr. Eugenio has been recognized for his contributions to the world of gynecology and endometriosis through many awards and has countless presentations and publications to his credit. He remains an active member of the Association of Gynecologic Laparoscopists and many other professional organizations. He has a dedicated interest in improving the landscape of endometriosis care through his vast advocacy efforts, and especially seeks to improve medical access in the Latin American community. To that end, he maintains an international practice serving patients in the Dominican Republic, as well as where he is part of the EFS Gynecology and Obstetrics team in Santo Domingo. Dr. Eugenio is a dedicated and compassionate physician committed to providing exceptional care and advocating for his patients' well-being. Interested patients may undergo a free consult with him at any time by visiting centerforendo.com, and we will place that in the chat. It's being placed right now. Selecting the free review link and registering for his case evaluation. Dr. Colon, we welcome you. Thank you for being with us here tonight. And for everyone
Thank you for the invitation, guys.
And for everyone who's logged on, once you have registered or once you're logged on with your name, we will be having a drawing for a free copy of the book, These Stones Remain, 60 Reflections on Finding Hope and Darkness Lingers by Claudia Campbell, and she has adenomyosis. So we will be having a free join at the end of the session for that book. So we welcome you. Thank you. And Dr. Colon, handing over to you at this time.
Hey guys, thank you for the invitation. I love it. I actually love talking a lot about different things and just focusing more on education. Because I think that's how we advance care. That's why we make sure patients are not gaslit. So it makes it everything a lot more fun, right? When everybody has a lot more information. So today I gave this talk last year, but I like giving it, especially now since, April is endometriosis, it's adenomyosis awareness. Even though, as I said on one of my recent posts, I actually hate the whole adenomyosis endometriosis awareness because it's not a 1 month disease. It should be that we're not tired of this. It's just talk and talk and talk about this all the time. Okay, so I feel a little bit under the weather, so I'm going to kind of run through the slides so we can kind of move more towards the a question and answer type of situation here. So this is basically for educational purpose only. Like, I give a lot of advice, but you should still have a conversation. It's basically the reason for the advice is so that you sit down and have a conversation with your primary provider, your local GYN, so that you can get way more informed about everything and have a lot more. I'm getting some issues with connection. Are you guys seeing me okay? Okay.
Yes, seeing you and hearing.
So that you guys could have basically proper conversations with your gynecologist. So right to the middle of it. So what is adenomyosis? So basically, it's not really well understood what adenomyosis is still, but we do know that it causes a significant amount of pain and suffering to women with endometriosis, right? So even though the origin of it remains unknown, there are a lot of different risk factors that are associated with the development of this pathology, but they are known, right? So several studies have found association between the number of pregnancies, the presence of adenomyosis, with a greater trend in those patients with a history of abortions. Although adenomyosis can appear in young patients, and there's a recent study that did talk about that it came out late last year, kind of discussing the incidence of adenomyosis in adolescent. And it's good because a lot of the times adenomyosis, as well, I'm going to mention later on, like it has a high association between adenomyosis, endometriosis, and fibroids, right? So sometimes the condition could appear in at the same time, or sometimes one and not the other, or different combinations of the three. But there is basically, we do know for a fact that it's actually way more common in older patients, especially when women hit 40. The finding adenomyosis is significantly more common. Now, there are other risk factors that also include like multiple previous surgeries or the use of tamoxifen in some patients. But basically, there is a inflammation associated characteristics of an adenomyosis. So like the uterus itself gets inflamed, and that can cause actually new blood vessels or angiogenesis to occur. And it's usually divided in two forms, basically, which is diffuse, which is throughout the whole uterus, or focal. And we'll talk about this a little bit more in next slides. So in order to talk about adenomyosis, we got to kind of review quickly the anatomy. So in this sonogram, right, we have the uterus. And if some of you guys have seen it before, you guys know that I'm a sucker for basically putting a lot of models. I have a whole bunch of different models of different uteruses in my office and things, so that we can kind of like go over and do colors to explain the anatomy, so that when you see the images, you can have a better idea of what you're looking at. So basically, this is a sonogram. This is the probe inside of the vagina, and we're looking at the uterus, right? So the uterus is this, in this colors that you see here. So the uterus has different organs. So the inner lining of the uterus is called the endometrium. And the outer layer of the uterus, or the bigger portion of the uterus, is called the myometrium, or muscle of the matrix. We Latinos call the uterus útero o matriz, or matrix. So it's kind of like a funny play of words. So the myometrium is divided into different areas. You have the outer myometrium, which is the basic core of the uterus, which is basically what's squeezed down in order to let the baby come out. You have the inner myometrium, or the junctional zone, which is where the endometrium and the actual myometrium fuse. Now, there is a membrane that separates the endometrium from the myometrium. And when this is broken, basically endometrial cells can actually invade into the muscle of the uterus, causing significant pain, right? Okay. Now, moving on, we have, how does the uterus look when it has adenomyosis? So you can have adenomyosis at the surface of the uterus, or inside of the muscle of the uterus, or more in the inner portion of the uterus, right? So a normal uterus looks like this on the left side. So the fibers are basically side by side, and when the uterus needs to squeeze, those fibers touch, and it starts to basically close. Now, in diffuse adenomyosis, the uterus is actually filled with multiple little holes like this, right? So it kind of feels like when you get a vaccine, right? You have water inside of a muscle, and when the muscle squeezes, it hurts. So basically, this is what's happening throughout the whole uterus, which can cause, as you can see here, as we mentioned, angiogenesis, or the formation of new blood vessels, which could be at the surface, but this can cause significant inflammation. Like, look at this is the regular color of the uterus, more soft, beautiful pink. And this is obviously a very bothered uterus right now with this like massive surface area of endometriosis and or adenomyosis here. Right now, sorry. So adenomyosis can also be diffuse. And how is diffuse adenomyosis seen? Just like this. So you have the muscle of the uterus, or diffuse. This is actually focal, correction. So diffuse is when it's throughout the whole muscle of the uterus and it's really hard to remove. Now, focal adenomyosis or an adenomyoma, it's when a specific portion of the uterus develops an adenomyotic area, but the rest of the uterus looks fairly normal. So this, this is easier to remove, and you can go open the uterus, remove the adenomyosis, the adenomyoma, because it's just a specific spot, and then you can close it in 3 separate layers to kind of give it strength, right? So these are simpler to treat than when it's actually diffused throughout the whole uterus. So in this particular case, it's a 34-year-old woman that was pregnant one time and was able to get pregnant earlier on in her early 20s. But subsequently, years later, after her child was probably 6 or 7, then she tried to get pregnant again, but she had over 6 years of secondary infertility. The first time she delivered was delivered by C-section, and then one of the most common risks or issues for infertility is what? Is endometriosis, but also adenomyosis can actually cause infertility. So she failed multiple IVFs, and she did intrauterine insemination as well, which also failed. And she noted that as the years continued to progress, she started to have heavier and heavier periods, which is one of the things that happens with adenomyosis. So when I took her for surgery, what did I see? I saw this. So this is the front face of the uterus, and then she had this plaque. So you can see normal pink tissue over here, but then she had areas of significant more inflammation. So then look at this area over here, really red, really beefy, inflamed tissue. So I'm able to basically lift up this plaque of endometriosis from the top of the uterus, or adenomyosis, and start shaving layer by layer, right? So the beauty about the CO2 laser is that it only cuts at a depth of 2 millimeters. So then here, as I'm shaving, right, I can quickly adjust. So that you saw there is basically a pocket of fluid. And you see how it looks black? It doesn't look like bleeding, but it's kind of the same type of fluid that you can see in like an endometrioma, but it's actually blood fluid trapped within the muscle that causes significant pain. So as I'm continuing to adjust, you see, I have to then now cut under that so that I can remove the whole plaque without leaving any lesions on top of the uterus in this location. So you can see how the muscle, as I'm shaving layer by layer, contains these holes that cause significant pain, because she could be bleeding into these muscles, which is basically the equivalent of getting multiple vaccine shots throughout the month, which obviously causes a lot of pain. But look how nice and pink the tissue looks after you cut it out, because of the way that the laser works. Okay. Now, there are multiple theories that are there that could increase the development of adenomyosis. So it has shared pathogenesis between adenomyosis and endometriosis, right? So we do know for a fact that patients with endometriosis can have an increased risk of having adenomyosis. But there's a lot of different talks recently on what's called the gene and aberrant gene expression, shared genes and aberrant gene expressions. So it's been said that they have around 30 to 40 genes in combination between adenomyosis, endometriosis, and also fibroids, right? So deep invasion of endometriosis into the myometrium can also cause angiogenesis, which also can actually cause progesterone resistance, which is one of those mechanisms of it's one of those things where they talk about how endometriosis can affect patients. But think about this. Progesterone resistance can actually be seen in patients with adenomyosis, but also endometriosis. So then if that's the case, why are we focusing treatments on not making treatments more individual, right? And just giving patients that are suspected to have adenomyosis, endometriosis, birth control, right? To give them progesterone. But the fact that they can actually have inflammation that can cause progesterone resistance Why are we not removing the disease instead of just masking it with some progesterone? Right now, there are several new talks in what's called basically the bacterial microbiome and how does this alter adenomyosis and endometriosis as well. So the symptoms are very varied and they can be very shared extensively between endometriosis and adenomyosis. In fact, approximately close to 90% of the time that we take a patient to the operating room, we find either or something abnormal, endometriosis or adenomyosis or fibers inside that can be the cause of pain, right? So the symptoms most commonly are abnormal uterine bleeding. Patients can complain of having significantly more clots or pain that's actually worse on the first and second day of their period. But endometriosis, these patients usually start having pain a couple of days before the onset of their periods. They can have anemia, they can have very prolonged bleeding, and the pain is usually worse on the second day of their period in patients with adenomyosis. And because you have adenomyosis or you're bleeding within the muscle, remember that when you're pregnant, the placenta attaches itself to the inner lining of the uterus, the endometrium. So the endometrium is right over the myometrium or the muscle of the uterus. So if you're bleeding into this, you can actually bleed behind the placenta, which can increase the risk of having pregnancy loss or infertility in some patients, right? So it's important to know. No, the diagnosis of adenomyosis is basically made on either MRI or sonogram. In exams, you can see that the uterus can be very large as well, but there's good techniques with transvaginal sonograms and MRIs that can actually see different types of adenomyotic lesions within the uterus. So in MRI detection, what do? You send a patient to MRI, which is a study that basically looks at the water content within tissue. So what do you see here? This is the patient that you're cutting sagittally. And those of you who have already seen me in clinic know that I go through anatomy with you very well so that you understand what you're looking at, right? So this is her spine, this is the back of the patient, this is the front of the patient, and then this is her spine right back here. Correction, there. So this is her spine coming down over here. This would be her tailbone. So this is her pubic bone, bladder full of water, which looks like this. Behind the bladder, you have the vagina, then the anus, and here. So this is stool, and this is the uterus. So look at this. So when we talk about that, right, in this type of cut, you have the uterus looking just like this, right? So it's symmetrical. So the front of the uterus is very similar to the back of the uterus, and it's divided in the middle by the endometrium here. So this is significantly thicker, right? This area is significantly thicker than the front. So this is the front of the uterus, this is the back. So adenomyosis is actually way more common in the back of the uterus than the front wall of the uterus. So this is very classic, but look, this is urine, right? So it's water, it looks whitish. Look at the muscle of the uterus here. You have some white areas because it's basically like it's swollen. So the muscle of the uterus itself can become swollen, which can cause significant pain in this patient. So ultrasounds can have specific features in adenomyosis, right? So you can basically see an asymmetrical thickening of the muscle walls of the uterus, which again, as I said, is more common in the back than in the front. And you can have these water cysts, right? Sonograms are different. So this is water on the sonogram back here, right? So these are this correction. This is kind of these black spots over here are kind of more water pockets. And then over here, you can see in some of these locations that you have water holes within the uterus. So that is basically like subendometrial cysts that can be causing pain that are usually encountered at very close to the junctional zone. So I tell always patients to look at your own studies, your MRI, so that you have an idea, MRI, read them in sonogram so you have an idea what they're talking about. And any words that you don't find, then you can Dr. Google this, which I love, or you can basically look it up on ChatGTP and have a conversation on ChatGTP on your images, so that on your reports, so that you can understand a little bit more, so you can have more poignant, more questions to ask your doctor. So when you see a sonogram, or an MRI or anything, describing the muscle of the uterus as heterogeneous is a very high indication that you have adenomyosis, right? So just some knowledge. So over here again, look at this symmetry in the uterus, and then here front wall, back wall, kind of the same. But the junctional zone is what the area that becomes a lot thicker. On this side, right? This is a hysteroscopy. So now we have a camera inside of the uterus, looking at the inside lining of the uterus. And now we see some of this, like you see holes within the muscle of the uterus. So if you have a placenta attaching itself here, that can cause significant issue because then it may not be able to get the proper nutrients, increasing the risk of miscarriages and abortions. So I love this study, and I always point it out. So they had 104 patients, right, in which they did surgery on. So they do, when we're doing surgery, we want to basically sometimes check the patency of the fallopian tubes. So we sometimes use blue dye, so inject it inside of the uterus. And we see the blue dye coming out the right and the left fallopian tube, which is this thing that you see here. But in these study, basically, they saw that 26% of the patients of the 104 patients studied had the uterus itself be the dye actually penetrate into the muscle of the uterus, right? And this basically was a clear signal that these patients had adenomyosis, right? Because remember the previous slides, they may have holes within the muscle, within the inner lining of the uterus, which allows that dye to go in, right? Into the muscle, and this is how it looks, right? So now look at this. In this particular study, right, or this particular hysteroscopy that was done, the patient had basically lakes of blood behind the endometrium. So if you have a placenta touching this and it bleeds, you can have basically blood behind the placenta, which can increase the risk again of miscarriages and abortions. So look at that. So as soon as they touch that, you had blood leaking out, right? So that is definitely abnormal, and it's seen in patients with adenomyosis. Right. So the prevalence of adenomyosis is around, basically this study in 2012 already was noting that the prevalence of adenomyosis was close to 20% of women, specifically when they're complaining of severe or very, very heavy periods, but also when they have a combination of pelvic pain and infertility, right? So we've known for a long time that adenomyosis is very prevalent with heavy periods, pelvic pain, and infertility. And the incidence, right, it's very difficult to quantify the incidence of endometriosis because there's no standardization in what's called non-invasive testing, right? But we do know that 20% of the patients that are approximately less than 40-year-old have adenomyosis, but even more, 80% of them when they're between the age of 40 to 50, right? But again, a recent study that came out last year or late last year is also talking about the incidence of adenomyosis in pediatric patients or in adolescent, right? So we do know that studies have showed that patients with adenomyosis can have a lower rate of pregnancy, and it can have significantly increased risk of miscarriage. This is because the inflammation behind the side of the placenta. Now, the true prevalence of adenomyosis, unfortunately, is unknown, and sometimes sonograms can be normal because the amount of adenomyosis can be very, very small. But this does not necessarily mean that they may not have it, because in fact, some patients that have a totally normal sonogram at the time of hysterectomy, they're shown that they actually have adenomyosis that's very small, but it was not sufficiently big to be picked up with a sonogram. Now, treatment plans for adenomyosis are varied, right? But you have to standardize the treatment or make the treatment more individual, depending on what the patient wants to do with her fertility, right? So the number one question is, does the patient want to get pregnant or not? So we need to talk about, like, what do we do? Self-management and adjunct treatments. We can do medical management of adenomyosis with medication, birth control, and different things. You can do interventional radiology treatments, which basically doing treatments to kind of like kill certain areas of the uterus to allow the uterus to reabsorb the areas of adenomyosis, specifically if they're diffuse, or you can have a surgical intervention. But the most important thing is that you need to have a shared decision making with your patient and basically do a patient-centered approach to make sure that the patient understands all the treatment options that they have. So what does self-management include? Heating pads, birth control pills, over-the-counter medications, anti-inflammatory massages, PT, biofeedback, acupuncture, yoga, Pilates, and make sure that they have an adequate support group that allows them to basically be able to tolerate pain a little bit more and live through this. Medical treatments is divided in multiple, right? One of the first things that we can do if we don't want to do systemic treatments is basically give the patient an IUD. So an IUD would basically deliver local progesterone inside of the uterus that is local, so it's not going to interfere with her ovulation and all the different things. But you could also do anti-inflammatory medications, and which would basically decrease inflammation. They're not going to remove the adenomyosis, but they're going to decrease the inflammation and make it easier for the patient to live with adenomyosis per se. You can also give the patient oral contraceptive pills that are going to be sufficient to decrease, again, more progesterone to decrease inflammation. But you could do different medications like Lupron, or different medications that are going to be basically affecting the GnRH agonist or antagonist, which are going to basically cause a massive drop in estrogen, which may have a lot more side effects. But again, it's to cause a decrease of the stimulation of the estrogen effect on the uterus. You can use danosol, progestins, aromatase inhibitors, and then dopamine agonists and oxytocin antagonists to kind of decrease the cramping and contractions in the uterus. Now, interventional radiology, what they do is basically they could do stuff like uterine artery embolization. So what is this? They would go in, put catheters through your arteries, and inject little blebs or little pellets into the uterus to decrease the blood supply to the uterus, which would basically kind of cause a tiny little infarct in the areas of adenomyosis, and then cause these areas to die off and the body to reabsorb them. Now, it's controversial because if you do this, the body could reabsorb some of these areas, but then it could seriously compromise the blood supply to the uterus, which would not be beneficial if you're trying to get pregnant in the future. Now, there are other studies like the HIFU, or high frequency ultrasound, in which you basically send high sound waves to the, or really, really sharp sound waves to the uterus that can kind of coagulate the areas in question without the patient needing to have significant surgery. Now, you could also do ablation of them with radio frequency to burn the blood supply of the adenomyosis, and in this way decrease the growth of them. Now, the other treatment options that we have is surgery, which is minimally invasive, in which we can basically do robotic or laparoscopic surgery, especially if you have a focal adenomyoma. You could do something like the Osada procedure or a longitudinal or transverse H incision, so that you can remove the adenomyosis and then close it in multiple layers to give back strength. Because imagine when you cut the uterus, you're kind of making a big hole that you have to repair. But depending on how you're repairing it, the risk of having a uterine rupture in labor is possible, right? Now, hysterectomy is the only known cure for adenomyosis. So the uterus gets damaged, you remove the whole uterus. Now, the good thing is that you could do a hysterectomy that is a total hysterectomy, meaning uterus, cervix, and fallopian tubes, or a subtotal hysterectomy, meaning uterus, fallopian tubes, but no cervix. Why? Because adenomyosis has not been shown to be encountered at the level of the cervix, just at the body of the uterus per se. Now, when you do a hysterectomy, you could do it with or without taking out the ovaries, but personally, I do not love castrating women, so removing ovaries before the age of 50 is something that I really, really avoid. Right? Nonetheless, there are some indications for it. Now, unfortunately, there's so many research out there regarding adenomyosis, and there's a lot of stuff that's still not really known. But what we have to do is make sure that when we find it, we make treatments individual, and we continue to listen to our patients so that we can continue to provide adequate patient care. Okay?
Thank you so much, Doctor. And we have a lot of questions. So I'm going to start with, we got some questions before the session started. So I'm going to start with this one. Is it possible to have a confirmed bulky uterus from an endo specialist and no other signs of adeno and not have adeno? Basically, can a bulky uterus be normal and not be adeno?
So it depends, because, for example, like I've done surgery in patients that have a really bulky, floppy uterus that's absolutely enlarged, right? But it also depends on when was the surgery done, when were you on your cycle, and if you were on hormonal suppression or not, right? Because you can have an enlarged uterus that could be very soft and boggy, because progesterone makes the uterus soft. So if you have an IUD at the time of your surgery, progesterone can actually make the muscle of the uterus a little bit softer, so it could look adenomyotic or swollen, right? Now, it's also important to understand that if you are on hormone suppression and you do a hysterectomy, the hormone suppression can actually suppress the possibility or decrease the possibility of the pathologist finding adenomyosis at the time of surgery, because you're decreasing the amount of glands that they may find embedded within the muscle of the uterus. So you may have adenomyosis, but it's still not not that overt. So that's why they came out with this study in teenagers, because they thought that adenomyosis was not prevalent in teenagers, and it's a disease that you would see in women that are older than 40. But you can still see it in teenagers, according to multiple studies recently. Okay. Um, so that's kind of the best way to answer that question per se.
Okay, thank you. Endometriosis prevalence rate is touted to be 1 in 10 women. Is it the same for adenomyosis?
So it's thought to be basically 20% of all women on average. So we have to say, like, it's significantly less. So I would say 1 in 20. Oh, actually more, correction. Uh, um, you know, 1 in 5 women would have adenomyosis, correction. If we go by that statistic per se.
Mhm. Which is so strange to me because adenomyosis is less talked about than endometriosis, and for it to
Yeah, it
affect
is. It is. It is.
and
I
for it
mean,
to affect
patients with
more women.
adenomyosis can have sometimes even more pain than patients with endometriosis, right? Because first of all, pain is individual. Um, but most importantly, it's because it's easier to dismiss a woman when you have an imaging or a sonogram, and then the only issue is pain with periods. But they say, well, we'll give you birth control, or we'll give you an IUD, because it's the uterus. If you put the uterus to sleep, the quality of life with a woman with adenomyosis would improve significantly more than with a woman with endometriosis. You see, because it's that what's inflamed is the uterus itself, the actual uterus. So if you put the uterus to sleep, you would improve the quality of life of these patients. But you may be able to put the uterus to sleep, but may not necessarily remove all the scar tissue, all the drama that happens from the horrible disease that endometriosis is. Like, once something is stuck and you have endometriosis, is stuck. And the only way to get it out is by surgery, or unstick it is with surgery, right? Adenomyosis is not the same, because you can have adenomyosis, but your ovaries are not stuck together. Your colon is not affected from adenomyosis. So then that's why it's talked about, I think, significantly less than endometriosis per se.
Fair enough. Okay, what's the best way to manage an adenomyosis pain?
So a combination of anti-inflammatories and IUDs, if you don't want to get pregnant, in my mind, is the best way.
Okay.
Right? But if you don't want to get pregnant at the moment, but if you don't want to get pregnant ever, then a hysterectomy may be a good way to remove the uterus. The same way, because but when I say a hysterectomy, I need to make sure that we understand. Hysterectomy is uterus, cervix, and tubes, not the ovaries. When they talk about taking out your ovaries, that is the same as saying female castration, cutting out your ovaries for funsies, right? So, which is why we have to make sure that we protect ovaries out there. Like, I absolutely hate cutting out ovaries if it's not needed, because like there are very few things in life that you can kind of tell a man that he has, and you're going to cut out his testicles. So we should be super jealous about our ovaries, right?
Yes.
Despite the fact, but it's all about like educating patients, understanding that if we're leaving the ovaries, right, the ovaries have significant benefit in the well-being of a woman.
Mhm.
Right? But ovaries, we do understand that endometriosis and adenomyosis can be affected by ovaries, by the estrogen produced in the ovaries. So we have to weigh in, you know, that's why we have to make sure that the treatments are very individual,
Yes. Patient-centered.
patient-centered,
Yes.
patient-centered.
Okay. We had quite a few questions about the new microwave ablation. Does that work? And does it work for diffuse as well as for focal adenomyosis?
The what? I'm sorry, questions about what?
The microwave ablation. So we had quite a few questions about that.
Yeah. So it's a new technique. It has shown good results. Um, so and there's a lot of people I mean, it's not necessarily that new. It's been out for a while, but people, in the endo world and everybody kept like, oh, I'm informing you about this. I was like, okay, it's been out for some time. Right. And it has, in very specific patients, it has really, really good results. Right. But the technique has had complications. The technique is, it's a good technique, but there's like any surgery you can have complications. So I'm not bashing the technique whatsoever. Right. But like, it's just like in the hands of an expert, the results are better. Right. So that's kind of all I want to say about that. I don't want to get
Yeah.
myself in the hot seat, but
Yes.
that's kind of it. Right.
Okay.
But doing surgery with somebody that's focused on this and that to go in and remove the adenomyosis, if it's focal or if it's diffuse, but you have some focal points that are giving you a lot more issues, is important. But that's the importance of like doing a hysteroscopy at the time of surgery, right? Because the one factor that we can't control is where the baby is going to implant itself, right? Where did I say that the adenomyosis is more common? In the front or the back of the uterus? It's the back, right? So when you get pregnant, how do we tell the baby to only touch the front of the uterus and not the back? We can't. So those are one of those things that the hand of God has to be there and say, okay, this baby is going to try to stick to the front of the uterus. So you can have massive adenomyosis in the back of the uterus, but if the baby got implanted in the front, you're good. And if it got implanted in the back, it's not that you're going to have a miscarriage automatically. It just slightly increases your risk of a miscarriages or abortions or preterm delivery, right? Because if the baby is getting a good chunk of its blood supply from an area that is swollen, it may be substandard blood supply, which can cause a negative effect on the child. But who knows where the baby is going to implant itself? Nobody.
Yeah.
Nobody. I mean, not nobody, but yeah,
Can't
for
predict it.
those of us that are believers.
Yes. Can an endometrial lining of 45 millimeters be adenomyosis?
Kind of what?
An endometrial lining of 45 be adenomyosis.
45 millimeters. Not necessarily, because adenomyosis is not the endometrium. It's the myometrium. So you could have thickened endometrial lining. You may need a DNC, you may need different treatments, but it's not necessarily related to adenomyosis.
Okay.
But
And
if you have a very thick endometrial lining, you need to have an evaluation, biopsies, and different things, because it may be that you have a polyp, right? And maybe that is the reason why it's causing you to have spotting between periods or way heavier clots, right? Because remember, like when we look at the uterus this way, right? When we look at the uterus this way, what are we looking? It's symmetry, right? So when you get a cramp, the front wall of the uterus and the back wall of the uterus are squeezing together. But if you have a wall of the uterus that's kind of bent out of shape, it can't squeeze together. So you tend to bleed more, to get way more pain, and to have significantly more issues.
the next question, I think, sort of related to the answer you've given, but still want to ask it. Is all adenomyosis the same as the endometrium, or are there cases where the invading tissue is more similar to the endometriotic tissue?
What was that again? Sorry, you were cutting off.
Is all adenomyosis the same as the endometrium, or are there cases where the invading tissue is more similar
No,
to?
no, 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 no. So adenomyosis it's muscle. It's abnormal muscle within the. So it's like so a fibroid is a muscle fiber that basically continues to multiply, and has like a ball of muscle, which is abnormal, which can basically kind of die on the inside and cause calcifications, which is why it looks white, right? Adenomyosis is a different type of tissue, but it's
But
not endometrium.
but Jose, those areas of abnormal tissue,
Mhm.
are they histologically, are they the same as the endometrium, or are they more similar to endometriotic tissue?
So they're different from the endometrium. right? They're different from the endometrium, actually. It's kind of a cross between endometrium. It's hard to say. It's like a cross. I don't know how to put this into words properly. So you can kind of bleed into it. So you have an endometriotic-like area, but it also has significantly different aberrant muscle fibers. Because when you do the surgery, like the tissue is not as hard as a fibroid. Because a fibroid you can grab it, it's like a ball, right? And if it's been there for a long time, you can actually bounce a fibroid off a wall. But the tissue from adenomyosis is actually like goo. Right. I mean, I need to for next year or later on, I'll actually have more pictures of surgeries of
Okay,
that.
good. All right, the next question. I think this is a good one. Ultrasound and previous surgical photos show uterine enlargement and diagnose it adenomyosis. But then an MRI reports no adenomyosis. What do you trust?
Pathology. Pathology is what you can trust,
Yeah.
right? Because I mean, the uterus could be swollen for many different reasons. It could be usually swollen because of adenomyosis, right? But like, I usually trust more the sonogram than the MRI per se. Me personally. So the MRI is really good at telling you that you have diffuse adenomyosis, but the sonogram is really, really, really good at identifying. But again, it depends on who's reading it. So it's like because if I get an MRI, I read it myself, and I can say, well, this looks abnormal, this looks abnormal, but the radiologist is not the one doing the surgery. So the one that's supposed to be reading your MRI with you or the sonogram is your surgeon. Because I don't take anything at face value when I get an MRI. But again, depends on who's doing the MRI and who's doing the sonogram, right? Specifically now that there's a lot of people saying, oh, I do endo, and then they don't read the MRI with the patients, they don't explain the MRI with the patients, and they don't really read, they just go by, well, the radiologist said X, Y, and Z. Okay, what do you say? Do you agree? Do you disagree? Why do you agree? Why do you disagree? So that's that's kind of the thing.
Okay. If adeno is too small to appear on ultrasound, MRI, and the hysteroscopy, as you were explaining earlier, would any adeno present still impact fertility?
Well, that hasn't been studied per se,
Okay.
but we do know that like you don't have to have like overt adenomyosis to have a negative impact on fertility. Because I've seen patients that have really bad adenomyosis and get pregnant 1, 2, 3, 4, 5 times, like back to back, right? Because it depends on the amount of inflammation or where the baby is going to implant itself. Right? Because if it's going to implant itself in the good portion of the uterus, then it's not going to be an issue. But you can have a pregnancy implant itself on the bad portion of the uterus, and then the patient is going to have a delayed period because it's not a delayed period, it's actually a miscarriage that they're having. Right? So that's why it's kind of hard to talk about adeno because there's women that, oh, you know what, I didn't get my period this week, oh, but I started spotting yesterday. But I'm like a week late, but I started spotting. Well, you probably were pregnant. There's a possibility that you were pregnant, but the pregnancy didn't implant itself properly, and now you're having a miscarriage. And it's just going to have like a regular miscarriage. I've had patients that they've noted that they're trying, they get pregnant, but they don't want to know, so they don't even test.
Okay, somebody is asking about presacral neurectomy. What are the risks and benefits of this procedure?
So presacral neurectomy is basically a procedure in which they go in and they cut some of the nerves that are going to interrupting the nerves from the inferior and superior and inferior hypogastric plexus. So it's done basically to kind of decrease some of the nerve endings that are going to the uterus itself and the pelvis, which can overall decrease some of the sensation that you feel from adenomyosis, but it could also decrease bladder sensation and rectal sensation. So it can make some patients report having not necessarily feeling when their bladder is full or their bowel is full, or can sometimes have constipation. It's very rare that these things happen, but it's a very small possibility.
Okay. Okay. We have 10 more minutes of questions, everyone. So I'm just going to take the more generic questions, okay? Does pain usually go away after menopause with an adenomyosis?
Well, in most cases, it can. And why? Because what's happening? The uterus is not going to be affected by estrogen, so pain is going to go down
Okay.
because the
Yeah.
uterus is basically going to get reabsorbed, so it's going to be atrophied.
Okay. Great. Can the CA125 blood test help to confirm adenomyosis?
I'm sorry?
Can the CA125 blood test help to
No,
confirm
no,
adenomyosis?
no. It's not, CA-125 is not used to quantify adenomyosis because it's so. I think the last time I sent a CA-125 was like 2014, 2015. Like it does. I mean, a lot of providers send it, but I don't find anything.
Mhm.
I
Okay.
don't find any benefit to the CA-125.
125. Okay.
I mean, if you have a flu, CA-125, like my CA-125 is up because of the flu, right? So
Mhm.
it's very varied.
Okay. This question is sort of personal, but I think it's a good question to ask. If you
Mhm.
have done the UAE, how long does it take for the adeno to shrink, given the fact that it can grow back? Will I have to do another one?
It's really hard to say that. It's really hard to give an answer to that because it depends on the amount of the uterus that was embolized and the possibility of the uterus to form new vascular connections.
Mhm. If someone is breastfeeding, but they have adenomyosis and PCOS, what treatment options can be available for them? Or if any, they're
What was that? I'm sorry.
breastfeeding, they're breastfeeding, but have adenomyosis and PCOS. Are there any treatment options that can be used?
If I'm sorry, you're cutting in and out. What?
Somebody asks, they're breastfeeding and they have adenomyosis and PCOS and have been told that there's nothing that can be done with regards to treatment while they're breastfeeding.
Well, I don't breastfeeding treatment. So breastfeeding and adenomyosis and PCOS, how to treat it, right?
I think the question is what treatments are safe to use what for if you have adenomyosis and PCOS while you're breastfeeding. So a treatment that's not going to affect the breast milk.
So there are certain birth controls that are low dose birth controls that you can use that can help minimize the bleeding and the discomfort of adenomyosis while you're breastfeeding without negatively impacting that. Now, there's one treatment that you could do that will never impact your breastfeeding, which is an IUD. Because the IUD is going to go local inside of the uterus and deliver local progesterone to the uterus, and it's not going to have any systemic effect on you. Like you can have an IUD and still ovulate, right? So
Can adenomyosis be mistaken for fibroids on a transvaginal ultrasound?
no, they look very different in sonograms than in MRI. Like let's see, I'm going to see if I can do. Mm, mm, mm.
And while you're pulling up that picture, why take out a cervix during a hysterectomy?
I'm sorry.
Why take out the cervix during the hysterectomy?
So the cervix is so they're different. So there's reasons to take it out and reasons not to take it out. So if adenomyosis is not related to, it's never found in the cervix. So depending on if let's say that you're doing a surgery that is going really well and things are going fine, and then you have time to take out the cervix, then take it out. So then the patient will never need any type of issues. Now, the cervix is not involved in adenomyosis. So there's also good indication for just do a supracervical hysterectomy, not affect the whole vaginal length, not have to put stitches in the vagina, not increase the risk of vaginal cuff dehiscence or a rupture during sex in the future, right? Because if you cut the cervix out, there are risks to that. But but usually when you do a good closure of the vagina, then those risks are mitigated. Now, there are situations where you're doing a case that's super, super complex. And then in the best interest of the patient, you decide, you know what, even though they're supposed to, because it happened to me recently, like, even though it's supposed to be a total hysterectomy, like the uterus is diseased. So you could cut it out, leaving the cervix, because the cervix is never involved in adenomyosis or in endometriosis, unless there's a retrocervical nodule of endometriosis. So in patients with massive chronic pelvic pain, you can remove the uterus, ovaries, and everything else that you need without necessarily taking out the cervix. It's not something that you do commonly. It's more like a spur of the moment type of decision that you make based on the cases that you're seeing, based on how the case is progressing during the surgery. Now, depending on the patient itself, I usually, which is what I do most of the time, or 99% of the time, is to take the cervix out. This is what I prefer to do, so that we never ever have to remove or go back into this patient, right? So especially if she's had multiple partners, she's had a positive pap smear in the past, or like, because I don't never want any type of cervical cancer or issue to come back, right? Or patients to develop this. So if it's one less thing, remove it. It's really, 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 it's a good idea. But again, it always depends on the history of the patient and how the surgery is going at the time of the surgery.
Okay, we have 3 questions. I think the answers will be very brief, so we can just quickly go through them. Number 1 is, you explained that painful periods is a symptom of adenomyosis, but you explained earlier that painful periods is a symptom of adenomyosis.
Mhm.
But what if you are experiencing painful ovulation? Is that a symptom of adenomyosis?
So no, painful ovulation is not related to necessarily to adenomyosis, because one thing is the uterus, another thing is the ovaries. Now, patient ovulation can be caused by scar tissue. It can be caused by chronic inflammation, because when you ovulate, you rupture a cyst in your ovary that can cause this very slight increase in inflammation in the area. Because the cyst can break, and it can break in an area that you have a little blood vessel going through. And if that's the case, you can have significant issues with bleeding, and it can cause an inflammation, or you can develop a hemorrhagic cyst. So there are a lot of different things that can cause you to have painful ovulation, right? So, but one thing is not necessarily, painful ovulation is not necessarily related to adenomyosis.
Okay, all right, thank you. Second one is Lupron safe to take long term?
Is Lupron safe to take long term? Well, it depends on the indication for the Lupron, right? Sometimes they have to give you Lupron if you're going to do IVF treatments, because Lupron is going to cause a massive, rapid drop in it increases your estrogen for a little bit, and then it makes it super low. So that drop in estrogen is going to decrease inflammation, which is going to aid in pregnancy in the future. Because when you get pregnant, or when they're trying to make you pregnant, if inflammation is really, really low, you should feel significantly better, and it's going to make the possibility of normal implantation even higher.
Thank you. And our last question for you, doctor. What are good qualities to look for in an adenomyosis surgeon? In general, would an endometriosis expert be well versed in adenomyosis as well?
But I would say it's hard to say, but I would ask some questions like, how many adenomyosis surgeries have they done? Do the patients regularly get pregnant after adenomyosis? Like that question is very generic, so it's hard to say. But it's basically having a proper conversation with your surgeon, and then doing your research, right? You should go into different groups, and not only, oh, this person is in this group. Like, do research, talk to their past patients, have a post like, hey, I want to have surgery with X, Y, and Z. Can you tell me your experiences with them? And then a lot of women in the group are going to reach out and give you like a general overview of that. that specific surgeon, but number one is, I would say, just make sure that you do your research really well, because it's becoming harder and harder to say who's an endosurgeon and who's not. Right? Like there are doctors that are minimally invasive that are not, they say that they're endosurgeons, but they're doing a whole bunch of other things.
Yeah.
Right. So it's hard for patients to kind of see.
Thank you so much, Doctor. This has been a very informative session as usual. I know we did it last day, but we always have new people joining us, and I'm sure this was very helpful to them. Heather has placed some very helpful links in the comment section. So if you are seeking to get more information, the link is there. If you're seeking an appointment with Dr. Colon, the link is also there. If you're seeking for a free review with him, the link is also there. So just check out all the links in the comment section, and you can find Doctor on social media. He's very active, especially on his Instagram page. I'm always learning something new. So please go and follow him there. Doctor, we thank you so very much for joining us and for being just awesome to work with. Heather, we also thank you very much. We thank all of you lovely ladies for joining us. But before we close, we want to do the drawing for the free book from Claudia, who is also an adenomyosis warrior. And she has written a book about finding the light in the darkness of all of our experiences. So Doctor might have to jump off here. Doctor, I hope you feel better soon. Take care of yourself.
Bye, guys. Enjoy the rest of your
Bye.
day.
Good
Good
night.
night.
Bye, same to you.
While I pull up the drawing wheel, also want to mention that we have a fairly robust schedule for May for Mental Health Awareness Month.